I have known Steve for a long time. He is the chair of the endocrine neoplasia and hormonal disorders at MD Anderson. He trained at Johns Hopkins, a wonderful institution. He did medical school, fellowship, intern, residency, the whole 9 yards there. And he ultimately ended up at MD Anderson, setting up a world-class program. He has accolades too numerous to count, but I count him as an incredible teacher. We see him at conferences and a mentor. He has the program he's created at MD Anderson is amazing, and I think about half of his faculty are on the ThyCa advisory board, and we thank him for that. Without further ado, Dr. Sherman.
Thank you, Bob and Angel, for the welcome. And I can't see how many folks we have on in this virtual room. Bob, can you?
Right now we're up to 68.
68, that's fantastic. So, well, thank you so much. It's been a number of years since I've been able to participate in a ThyCa meeting. In fact, the pandemic, one of the silver linings was it actually opened my calendar in a way that it was much easier for me. So, it's really great to be back with ThyCa and trying to share. The topic that Gary and I talked about having a chance to discuss today is something that's pretty new in our field, kind of an interesting new approach to treating patients with thyroid cancer. And that's being able to give radioactive iodine to people who have thyroid cancer that is resistant to radioactive iodine, what has been called redifferentiation therapy. And I'll try to walk you through, talk about why this concept is necessary, how we've been trying to pursue it, and what the results look like so far. So, this is a patient who has a radioactive iodine scan, and where you see black, that represents where radioactive iodine is accumulating. And obviously what stands out in this scan are these two huge black areas, which are the patient's lungs. And this is a patient who has diffuse metastatic disease, spread of papillary thyroid cancer throughout the lungs. This, in fact, is one example of a patient with advanced metastatic thyroid cancer. Now, this patient over here on the right seems to be smiling, in fact. In reality, perhaps he shouldn't be, because his lungs actually have the exact same situation as the patient with the scan on the left. That is, both of them have diffuse metastatic thyroid cancer. The problem is that the guy on the right has thyroid cancer that doesn't respond to radioactive iodine. It is not sucking up iodine out of the bloodstream and concentrating it in a way that would allow radioactive iodine to work. So the patient on the left with the black lungs that looks like a much worse scan, this is actually a patient who could be cured of metastatic thyroid cancer with radioactive iodine treatment. And for the person on the right, that's a therapy that wouldn't work at all. And the question that we've had for a very long time, is can we somehow do something that converts the patient on the right, whose lung metastases do not respond to radioactive iodine, can we somehow convert it back to what's on the left? And why would we say that this is going backwards? Well, the normal job of thyroid tissue is, in fact, to suck up iodine out of the bloodstream and use it to make thyroid hormone. And so this is a normal function, what's called a differentiated function of thyroid tissue. The patient on the left has thyroid cancer that still retains that ability. It's the patient on the right who has a cancer that has moved beyond, that has lost some of those normal differentiated functions. And the question is, can we somehow retrain it to go back to what it should be doing? That has really turned out to be, for decades, the holy grail in trying to treat thyroid cancer. So let me walk you through a recent patient of mine. This is very recent. This is a patient who I treated with radioactive iodine literally a week ago, 8 days ago. So here's a patient who has evidence of thyroid cancer that has spread, an elevated thyroglobulin level, and we did a radioactive iodine scan to see whether there was anything, any metastatic disease that would concentrate iodine. And remember what you saw previously. It's those areas that light up in black, which is where the radioiodine is accumulating. And when you do a radioactive iodine scan like this, what you see are some areas that radioiodine normally accumulates into. So up here in this outline, let's see if I can get my arrow to work. Here we go. So up here, we see some areas that are darker, and that's iodine accumulating in the sinuses. And here it's iodine accumulating in the stomach and throughout the bowel and being stored up in the bladder as part of urine. And these two things outside aren't even in the body. These are some canisters of iodine that are used to help set up the radioiodine equipment, scanning equipment. And so on this first one here, all the way to the left is a view from the front, and this one here over is a view from the back. So all of that's perfectly normal. There's no evidence of radioiodine accumulating where it really shouldn't be, except that this patient has a chest CAT scan that shows lumps like this right here. You can see sort of at 1:30 on the clock. My arrow is trying to circle it. There's a nodule, there's a lump. It's about 1/2 inch in size in this patient's lung. And there's a lot of scattered, much smaller ones throughout. So it turns out this patient has metastatic thyroid cancer into the lung, but it doesn't show up on a radioactive iodine scan. And the question is, could we do something? Could we treat this patient in a way that might restore that iodine uptake? So we gave him 2 chemotherapy drugs, and I'll talk later about why we would pick these 2. But dabrafenib and trametinib, some of you may know them as drugs that we use in treating patients with anaplastic thyroid cancer or melanoma. But it worked for this particular patient. We treated for 8 weeks. And then this was his radioactive iodine scan after 8 weeks. And now you see lots of black accumulating in the lungs, and actually some strange spots here, right up here above the right shoulder, down here in the right thigh. And it turned out that this patient not only had spread of thyroid cancer into the lungs, but there were some areas where there was tumor that had spread into some of the muscles around his body. And last Friday, 8 days ago, we treated him with a very high dose of radioactive iodine. Now, let me walk you through the data that explains why this process may have worked and what we might expect it to do for his cancer. So if we go back in time historically, there were 3 primary steps that were used to treat patients who had papillary or follicular cancers, the so-called differentiated thyroid cancers. And treatment would normally start with surgery. Most patients would get treated with radioactive iodine, and that was primarily to get rid of any thyroid tissue that was still sitting in the neck that might have been left behind with surgery, as this patient here shows. And then patients would get treated with a high dose of thyroid hormone in order to suppress TSH, because that helped to prevent thyroid cancer from coming back. That was the classic modality. And this was how most patients got treated. Now, what we've seen over the last couple of decades is that we've gotten a little bit less aggressive. Patients are less frequently being treated with radioactive iodine right after surgery, and maybe with lower amounts, as we've realized that not everybody requires such an aggressive initial treatment. And same thing with thyroid hormone therapy, not quite as aggressive, not quite as high doses, because it turned out that for most patients it was unnecessary. But for those with metastatic disease, this would be the core approach to treatment. And we've been doing this since the 1940s. In fact, in cancer, very often the last 20 years, we've been talking about targeted therapies, treatments that target very specific abnormalities and get into or treat cancer cells very specifically. Well, really, the very original targeted therapy was, in fact, radioactive iodine. And this was written up in that famous medical journal, Life magazine, back now 71 years ago. Describing this patient here, here's a gentleman who had follicular thyroid cancer that was so abnormal that it was actually producing a very large amount of thyroid hormone, and he was hyperthyroid. It was just as bad as if he had Graves' disease. And as you can see, he was so thin, he'd lost a tremendous amount of weight from being hyperthyroid. And radioactive iodine had just been introduced a few years earlier for treating people with overactive thyroid. And so his doctors had the idea of treating him with a large amount of radioactive iodine to try to cure the hyperthyroidism, not realizing that it might also have an impact on his cancer. When in fact, in 1949, he became known as the first person cured of any type of metastatic cancer, not just thyroid, but of any solid tumor, by drinking these 4 doses of radioactive iodine and establishing what became a practice for 70 years, which is the ability to treat metastatic thyroid cancer and potentially cure it with radioactive iodine. What we've been doing is relying upon radioactive iodine, perhaps a little bit excessively. And so for many years, if a patient went through this standard sequence, but their tumor grew back and started growing despite radioactive iodine and thyroid hormone therapy, we would circle back and they'd go back for more surgery. They'd go back for more radioactive iodine. And frankly, if the radioactive iodine didn't work, we brought them back and we gave them more, because it was really the only tool that we had in our tool belt, right? And of course, if the only tool you have is a hammer, what do? You just keep hammering. But what we came to realize is that there were patients for whom radioactive iodine was not a successful strategy. And this schematic helps to give us an idea of the different types of patients for whom radioactive iodine really doesn't work. So spots in red represent metastases of thyroid cancer, spread of thyroid cancer that doesn't take up or concentrate iodine, doesn't suck it up out of the bloodstream. And so you can't get radioiodine to work. Whereas if it's green, it means radioiodine gets in. And the ways that we can think of, or in these cartoons, the ways that we can define or describe cancer that doesn't respond to radioactive iodine is as the following. So first, all the way over here on the left, is a patient who has spread of thyroid cancer with no uptake anywhere. You can do a scan and look to see where the radioiodine accumulates, and you can't find those tumors, like some of the pictures that I showed you before. And you will not be able to get enough radioactive iodine sucked up into those spots to give off radiation and kill off those tumors. It just won't work. In the middle, you have a patient where it's sort of a mixed picture. They have some that are green, but unfortunately they have some that are red. And really the tip of the iceberg, the areas that are going to be problematic and that are going to predict how that patient will do, really are the ones in red that are not taking up radioactive iodine. So it's great if you can get some benefit for these spots in green, but eventually they're going to turn into spots that are like the red. So we have, as long as there's at least one major lesion that doesn't have radioiodine uptake, you're probably not going to be able to cure that patient. And then finally, we have patients like the one over here all the way to the right, where you get good, what looks like good uptake of radioactive iodine, but despite that, the tumors grow anyway. And so you can see over here several spots that even after a few months, after radioactive iodine, after what looked like good treatment, the tumors progressed anyway. These are different ways of thinking, but they all come down to patients with what are now called radioiodine refractory or resistant thyroid cancer. Now, what's the significance long-term to this? Well, it's a huge difference in terms of how patients survive, how long they live from that point forward. And these are two different studies that are looking at the exact same thing, which is what's the survival of patients who have thyroid cancer, metastatic thyroid cancer, based on whether the tumors do or do not respond to radioactive iodine. And again, let me see if I can get my arrow to work here. Hopefully you can see it. But on each of these graphs, the line that's higher up represents patients who have longer survival. This higher up line here represents patients whose tumors concentrate or take up radioactive iodine. And you can see that after 400, 480, or 500 months, all the way out here, about 60% of them are still alive. So years and decades later, patients survive their thyroid cancer, the majority of them, 60% still alive. Whereas if they don't have radioactive iodine uptake, you can see in this lower line that the percentage of those that are still alive after a certain amount of time keeps dropping very quickly. And that's just one study, but here's another one as well that shows roughly the same thing, that patients who have no radioactive iodine uptake have a far worse survival, a much more quickly dropping line than those patients who do take up radioactive iodine. So it clearly indicates that these are patients who are going to have more aggressive thyroid cancer, who are at greater risk of problems or death from their disease. So it's a bad sign to not have radioactive iodine uptake. So in the last 15 years, we now know that there are a variety of chemotherapies that have been developed that allow us to kind of get out of this cycle of futility here of going back to more and more radioactive iodine. And the so-called TKIs or kinase inhibitors have been introduced, including the drugs lenvatinib and sorafenib, which you may know as Lenvima or Nexavar, which are actually FDA approved for treating patients who have radioiodine refractory thyroid cancer that's progressing, that's growing, despite this initial approach up front. And there are other kinase inhibitors that can be used as well, although lenvatinib and sorafenib are the ones that are best studied in thyroid cancer and that are FDA approved. Well, what does this have to do with radioactive iodine? Let's go back to trying to see if we can take our old friend, the tool that we've had, and restore that ability to work. This is not a new concept. This is actually research has been going on since at least the 1950s, trying to figure out why tumors don't respond to radioactive iodine and what could be done to treat it. In fact, one of the very first laboratory researchers, one of the very first basic scientists ever recruited to my institution, MD Anderson, was recruited about 1950 to study the very specific question of how does the thyroid acquire or gain the ability to concentrate iodine normally as a means of understanding how does it lose it in cancer. So soon after that first patient got treated in the 1940s, we were already learning that it didn't work for everybody and we needed to try to understand why. In the 1980s, there were a number of studies that began focusing on vitamin A derivatives. And there was some evidence that if you gave high doses of some of these, you might get iodine back into thyroid cancer cells. That seemed to work in the laboratory and even in some patients. But regardless, it didn't seem to make any clinical benefit. These tumors grew despite apparently being able to suck up iodine again. And the same thing's been seen with a number of other agents, from the diabetes drug that's now been taken off the market, but rosiglitazone, which was used for many years for treating type 2 diabetes, leukemia drugs, azacitidine and decitabine, that work by modifying chemically the genetic material in the cancer cell. Even one of the current TKIs, sorafenib or Nexavar, was studied to see if patients who got treated with it might regain the ability to respond to radioactive iodine. So these have been studies that have gone on for a long time. And the reason that none of these drugs are used for this purpose is because clinically it didn't seem to help patients. It didn't seem to really provide any benefit, even if they did restore a little bit of iodine uptake on a scan. So are there other strategies, other approaches that we can take besides those that I described? And this is really kind of taken us to the question of, are there certain genetic modifications, genetic abnormalities in these cancer cells, so-called oncogenic mutations, that represent a susceptible abnormality, the Achilles heel of these cancers, that might allow us to reverse the inevitable loss of radioiodine uptake and treat these patients with radioiodine again. And to do that, we need to understand in this very simplified schematic, what are the genetic abnormalities that lead to developing papillary and follicular thyroid cancer? And so there are three main abnormalities that are seen most commonly. The most common is a mutation in a protein in the gene for a protein called BRAF. Next is for another one called RAS. and then finally the so-called RET-PTC. These are all so-called kinases that transmit signals that start out from the outside of the cell and down through a pathway, sort of like turning to your neighbor and whispering in their ear, and then they turn to their neighbor and whisper in two ears. And these signaling pathways end up stimulating growth of cells. That's something that's supposed to take place normally, and it allows for normal regulated growth and proliferation of tissues. However, in cancer, if you have a mutation in one of these kinases, it causes an overabundance of signal. It's like you pass on a message and you can't stop it. And it ends up being multiplied as it goes down these pathways, in this case from RET-PTC to RAS to BRAF, next on to something called MEK, and then ERK. And each step along the way, the signal gets amplified. And if you have these mutated signaling proteins, these end up with a hugely multiplied signal saying, grow, 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 grow. It turns out that with some of these mutations, especially the so-called BRAF mutation, one of the end results of that mutation, of that grow, grow, grow signal, is loss of differentiated functions like the ability to take up radioactive iodine and respond to it. And so when that was realized, that these mutations were actually directly causing the loss of radioiodine uptake, it led some very smart scientists to ask the question, if we somehow could use a drug to interrupt those signals and turn it off, could we not just prevent the growth of tumor, but actually restore the ability to treat with radioactive iodine? So this was a very beautiful experiment out of Jim Fagan's laboratory at Memorial Sloan Kettering in New York. And what they did was they took this mouse over here, this poor mouse, and they were able to modify the genetic material, the DNA in this mouse's thyroid, in such a way that they could turn on or turn off the BRAF mutation, the same mutation that causes aggressive forms of thyroid cancer in humans and the loss of radioactive iodine uptake. And so then this mouse was subjected to a radioactive iodine scan. And let me just show this one as an example. Where it's yellow in this scan is an area of intense iodine being taken up, and where it's black or blue or green or even red is much lower amounts of iodine. So the bottom line here is this: when they turned on the BRAF mutation in this mouse's thyroid, you see very low amounts of iodine accumulating. But all the way over here, if they treated this mouse with a drug that inhibits the mutated BRAF, they restored iodine uptake. And same thing if they used a drug that, that targeted the next kinase in that pathway, the so-called MEK kinase, they could also restore iodine uptake. So they had this beautiful mouse model of being able to turn on and off radioiodine uptake in a very clever way. Question is, would this work in humans? Now, obviously, you don't want to put in a BRAF mutation and reproduce this same experiment in humans. But instead, what they did was they took patients who had metastatic thyroid cancer that, just like the other patients I showed you of mine, these patients had metastases that were negative on radioactive iodine scans. And they treated these patients, it was about 20 patients, and they treated them with an experimental drug that targeted the MEK kinase, the one that I showed you just before, the MEK signaling kinase. And this is a radioactive iodine scan, or a type of scan that was done before the treatment. And this is one after the treatment. And all of these black spots that you see that showed up in the patient's chest represent areas of tumor that now take up radioactive iodine. Down here is a different kind of scan showing before there's a big hole in this patient's pelvis, and afterwards it's lighting up bright white, showing intense amount of radioiodine accumulating there. So the principle was take these 20 patients, give them this chemotherapy for a couple of months, for 5 weeks actually, and see whether you could restore iodine uptake. So great, they showed that they could. What was the clinical outcome? Well, out of these 20, they estimated in a subgroup of them that perhaps there was so much radioiodine uptake that was now accumulating that they could actually get an adequate treatment, radiation treatment, if they gave the patients radioiodine therapy. So they were able to treat 8 patients out of the original 20. And this is what's called a waterfall plot. You may have seen these in presentations about drugs like lenvatinib or sorafenib, the chemotherapy drugs. And each of these vertical bars represents the change in tumor size in an individual patient. And if the bar is going downward into the negative area, then that's some degree of tumor shrinkage. And if the shrinkage is by 30% or more, that's usually considered a partial response. And in green or blue-green, depending upon what your eyes are telling you, in blue-green represent the patients whose tumor shrunk enough to qualify as having an objective partial response, meaning it didn't go away, but it shrunk quite significantly. So 5 of the original 20 patients got to that point, have that sort of blue-green picture. So let's do the math. 5 out of 20 is 25%. A quarter of the patients who went through this treatment program seem to get significant shrinkage of their tumors. This has been seen not only with experimental MEK inhibitors, but this has been seen with BRAF inhibitors, such as the drug dabrafenib or vemurafenib. 20–25% likelihood that you can get some significant shrinkage of tumor. That actually is a little bit disappointing because it says that we did not restore dramatically enough the radioiodine uptake to really shrink tumors, and maybe it's all maybe not quite that helpful. If you say, what does chemotherapy by itself do? The response rate to a drug like lenvatinib is about 60%. So this whole strategy didn't seem to work quite as well as just giving the patient, the conventional chemotherapies that we have. But let's go on a little bit more and talk about what we've seen. These are some patients that we've studied at our institution and published a couple of years ago. And again, just as you've seen before, sort of these scans before and after this redifferentiation therapy with different chemotherapy drugs and restoring the ability to treat with radioactive iodine. And with some of them, it's really quite dramatic. If you look at this patient, and especially this one up here in the upper right-hand corner, really an incredibly impressive restoration of iodine uptake, this big, huge black blob over the lungs. In fact, this patient, when treated with radioactive iodine, actually had so much uptake restored, so much radiation to the lungs, that they actually got some inflammation and damage to their lungs. So we learned to be more careful with how much iodine we give these patients. So what ended up happening to these folks? What may be the benefit besides making these very pretty scans? Well, like the Memorial Group, we looked at what happened in terms of tumor changes in size, and you can see that some of them, the bars are going up, meaning tumors actually seem to grow, and in others, they seem to go down. And overall, we only saw about 10% of patients having significant tumor shrinkage. But look over here at the SD, which stands for stable disease. And there, the majority of patients seem to fall into that category, to have stable disease. Now, what does that mean? Well, these were patients who had tumors growing, often by 20, 30, 40% in a year. These patients had fairly rapidly growing metastatic cancer that was not responding previously to radioactive iodine. These are the kinds of patients who would typically get started on drugs like lenvatinib or sorafenib. And then, as you may know, when you start those drugs, even if they shrink down tumors, they don't tend to make them go away. So you stay on those drugs for as long as they're still working. That might be 6 or 8 months. That might be 1.5 to 2 years, which is about average, or maybe even longer. And I've had some patients who've been on drugs like these for 10 or 15 years now, but continuously remaining on chemotherapy. But let me tell you the secret about these patients who got chemotherapy with redifferentiation. We treat them for a couple of months with drugs that target BRAF or MEK. We restore that iodine uptake, and then we stop their chemotherapy. And sure, you don't get a whole lot of shrinkage, but in terms of significant growth, the average patient went 14 months before they had to be treated again with chemotherapy. So in fact, what we did through redifferentiation was we were able to provide patients with prolonged period of time without any chemotherapy at all. Chemo-free, no side effects from chemotherapy, no cost of chemotherapy, which these drugs can be 10, 15, some of the newest drugs, $35,000 per month off chemo for over a year. And then what we've been able to see is that in some patients, we can repeat this process again if or when their tumors start to grow again. So the bottom line is that we're beginning to see that we are at the cusp of being able to restore more normal function into these cancers, the ability to respond to some degree to radioactive iodine, get some control over their disease with a short-term burst of chemotherapy and another treatment with radioactive iodine. Is this the end of the road? No, I think that we're working on trying to figure out how do we optimize this, which drug or combinations of drugs might work better to achieve this. Do you just have to use BRAF or MEK inhibitors? Perhaps not. We're beginning to see with some of the very new, highly targeted new drugs that you may have heard about that target mutations in less common genes like TRAC, that you may also get some of the same effect. So hopefully we're going to continue over the next few years to be optimizing this and create a whole new approach to perhaps being able to use a lot less chemotherapy and a lot more of our old friend radioactive iodine to control patients' tumors. So we now at MD Anderson have an algorithm, a path that we follow that's based upon the genetic abnormalities that we might detect in a patient's tumor in deciding what type of treatment to use when it's refractory to radioiodine and growing or progressing. And we look for different mutation types to help figure out what sorts of therapies they might need. But many of these patients end up down here where after they've been treated with either a BRAF inhibitor with or without a MEK inhibitor or a MEK inhibitor by itself, that we may be able to retry radioactive iodine and get some greater benefit and quality of life by being able to keep people off of chemotherapy. So I just want to take a second to thank my colleagues at MD Anderson. These are the other faculty members that were referred to earlier on. Just about everybody in this picture, except for two, are folks that I've recruited over the last 20 years to the MD Anderson. And some of the folks that have really been most notable in this redifferentiation effector studies at Anderson are down in this left-hand side of the picture. Mimi Hu, Naifa Busaidi, Stephen Wagspack, Ramona Dadu, Maria Cabanillas are folks who have played a very major role in developing our treatment pathways and our approach to using redifferentiation. I hope that this has been valuable.
Yes, thank you, Steve,
Yeah.
very much.